Now we go to our third presentation, an organized approach to the nystagmus by Dr. Parton.
But what I hope to do for you today is to really try to accomplish three things when talking about nystagmus. And the three things are, one, to kind of give you a way to think about this so that when you see someone whose eyes are moving, you have a way to try to approach it and try to logically dissect out what you think is going on. Two, for each of the kinds of nystagmus we're talking about, give you some of the key points, the key clinical points you need to think about. What does it mean and what should I do? What could be going wrong with this patient? And the last thing is to show you some of these examples so that you know what they look like, because often, as with many things in medicine, it's pattern recognition. You know it not because you can go through a book and read about criteria, but you know it because you've seen it, and you know what it looks like. So that's what we're going to try to do today. So just to remind everybody, what are we talking about? Nystagmus is a rhythmic oscillation of the eyes, and it has to have a slow phase in at least one direction. The fact that it's rhythmic and it's got a slow phase is what distinguishes it from saccadic intrusions. And saccadic intrusions don't have a drift. They're just a bunch of saccades, and they tend to come in little bursts and somewhat chaotic. Nystagmus is not chaotic. It's fairly regular. If you have a sinusoidal oscillation where it's all slow phases, no fast phases at all, that's pendular nystagmus. If you have a slow drift in one direction, which is then corrected by a fast twitch in the other direction, that's jerk nystagmus. And that's going to be an important distinction you have to make. And in terms of the way I like to think about this, one of the things that you do try to make a distinction at the beginning right away is congenital versus acquired. I am not going to show you any examples of congenital nystagmus today. I think most of you have seen this. And what I want to do really is show you some of the things that maybe are less familiar to you. And acquired nystagmus, again, that's where we make the distinction right off the bat as to whether you think it's pendular or jerk. The pendular nystagmus has a bunch of categories under this thing. There isn't really a way to organize this. You just have to know the list and know what they look like. And I'm going to try to show you those. More commonly, what you're going to see, though, is jerk nystagmus. And jerk nystagmus, what you want to do there is think about where do I see this? And did I have to do something to bring it out? In primary position nystagmus, that means that you can see it most of the time just looking straight ahead. That doesn't mean it's always right easily visible to you. It may be that you have to look with the fundoscope to see that the eyes are actually have a little jerk drift going on. But you should be able to see this in primary. And we quite logically divide those into whether it's beating down, that means the fast phase is going down, and the slow phase is drifting up, upbeat, torsional, horizontal, or mixed, which means it's a combination. If it's mixed, the most common thing is horizontal torsional. That almost always implies peripheral vestibular disease. On occasion, you can see it with lateral medullary lesions. Again, that's one of the things I'm not going to talk about too much today. We're going to talk about some of these more unusual beasts. Provoked nystagmus means you don't really see it when you're looking straight ahead, but you have to have the patient do something before you bring it out. The most common of all is gaze-evoked. And that means that you only see the nystagmus when they look off to the side. And that is, of course, for us, probably the single most common form of nystagmus you'll see. Especially if you're a neurologist, you've got people on antiepileptic drugs, that's where you'll see it. Positional nystagmus means that you can see it in primary at some point, but you have to move their head or their body in some way. And of course, the classic version of this is benign positional paroxysmal vertigo, where you get the person to look up or look down or lie them down, and suddenly the eyes start to twitch and feel vertiginous. Okay, so that's how I think about it. Pendular versus jerk. Jerk in primary position, which way is it going? It's not primary position, what did I have to do to bring it out? Is it gaze provoked or is it positional? So, let's show you some of these things. So we're going to talk about the pendular nystagmus first. This is acquired pendular nystagmus. And it can be quite asymmetric. You see in this woman, by the way, I'm going to try to show you big videos of this as well, of these rather smaller versions. Let me know if you have trouble seeing it. But I think you see the eyes kind of jiggling oscillation back and forth here. It's not got a fast phase. It goes away with convergence in this woman, and then it comes back again when she looks off in the distance. And You can see it's really much more pronounced on this eye than this eye. And that's quite characteristic. This can be symmetric, but it can often be asymmetric, even to the point of being monocular. And it can be disconjugate in the sense that if one eye is going in one direction, the other eye can be going in an entirely different direction. But they tend to go at the same frequency. It can be in any direction. It can go horizontal, vertical, circular, elliptical. It's very variable. And most often these patients do complain of oscillopsia, except if they have also an associated optic atrophy that makes their vision rather poor to the point where it's hard for them to appreciate the movement of the image. And the reason why they might have optic atrophy is because the most common cause of this disorder, or the most common scenario, is multiple sclerosis. We worked out some years ago, the incidence in our population was about 2 to 4% of MS patients would have this. If you find somebody with this, there's two things you should look for or figure the clinical characteristics of the patients who have this. One is they tend to have other cerebellar signs. In fact, most of them come into our clinic in a wheelchair because their gait is so bad. And the other is that many of them also have signs of optic neuropathy. So those two things you should look for, optic neuropathy and cerebellar signs in these patients. If you were to do an MRI on these patients, you might see something or you might not. The classic lesion is in the pontine tegmentum. This is one of the few nystagmuses for which we have some reasonably good evidence for therapeutic effect from a randomized controlled trial with either memantine or gabapentin. I will say that I don't think the effects of these things are miraculous. They do have some improvement, and maybe a little improvement is enough to make life easier for the patient, for them to read and do things like that, but it doesn't eliminate the nystagmus entirely. And again, just in case you missed it, this is a larger version. I think you can see it here. And fair enough. Okay. Everybody can see that? So you all have a reasonable visual acuity. Okay, so that's one. Number two, this is less common. Seesaw nystagmus, but it's a fun one because it's pretty bizarre looking. The key here is that it's got a stereotyped trajectory. It's not the freewheeling thing that acquired pendular nystagmus is. This has a very characteristic trajectory, and it's essentially the hallmark is that as one eye goes up, the other eye goes down. That's why it's called seesaw. Hello. The two scenarios in which you'll see this. One is with visual dysfunction, and that can be one of two types. Either there's an optic chiasm lesion with a bitemporal hemianopia. How's the color in this thing, by the way? Is that actually green? No, huh? I was going to tell you that the green things are clinical signs you need to look out for. So bitemporal hemianopia is a key clinical sign to look for in these things. And that could be either tumor, trauma, or congenital. This happens to be somebody with agenesis of the optic chiasm. Or it could be a retinal problem, which could be like cone rod dystrophy, receptor optic dysplasia, and so on. And the idea is that there's a problem with visual input to the accessory optic system to stabilize gaze. That's the root problem here. The other possibility, number two, is that there's brainstem damage, and that could be damage to the vestibular nuclei or the interstitial nucleus that could have up here. And that impairs the ability of these systems to stabilize gaze as well. The prognosis does depend upon the lesion. There is some therapeutic anecdotal information that maybe ethanol might help this, but I haven't had a chance to try that out yet. So here's this example again. Look at the nose. Instead of nose, and you'll notice that if you look at the nose, this side is going down and this side is going up. Do you get that sense? So that's seesaw nystagmus. Number three, oculopalatal myoclones. Again, very characteristic sign you want to look for here. Here there's a little bit more variability. It's a slow oscillation. It can be either symmetrically purely vertical, or it can be what we call a hemi-seesaw pattern vertical torsion. The difference between this and seesaw is that it's not the case with seesaw where one eye is going up and the other is going down. Here, both eyes are going up, but one eye is going up far more than the other, as if two people were sitting on the same side of a seesaw. Okay, so let's just look at that. So if you watch, this eye goes up much further, this eye goes up just a little bit, but they're both torting at the same time. And if you see that pattern, you should then look inside the mouth and see if the palate is doing that. And you can see that the palate and the eyes are sort of going at the same frequency. It's not always just the palate, though, despite the name. Sometimes it's the tongue, sometimes it's the chin or the platysma that you can see twitching away. And if you do an EMG in the eyeballs, you can actually see some clinical oscillations there as well. The funny thing about this, then, is that when it tends to occur with a lesion, it tends to occur months to years after the inciting lesion. And usually that inciting lesion is something like an infarct or a hemorrhage in the brainstem. So it's actually like a super sensitivity, long-term problem that emerges after time has passed. The lesion usually is something we call Mahler's triangle, which is going from the dentate nucleus to the red nucleus, back down through the central tegmental tract down to the olive down here, and then back into the cerebellum. That's a gaze stabilization circuit. So you see in this man here that I showed you, he had this Ponting stroke some months before, and after a while, what happened was he developed this delayed inferior olivary hypertrophy here, which you can see is this kind of higher intensity signal with a larger olive on that side. That's the key sign you're looking for to accompany this, the inferior olivary hypertrophy. We don't really know for sure what might improve this. There are anecdotes that Valproate or triaxophel or clonazepam might help. And just to show you this one more time, again, you see both eyes when they go up, go together. And the butterfly goes further than the other one. And there's a palatal movement. And again, trying to show you all the eyes and palate at the same time. Last of the patient ones I'm going to try to do today is nystagmus mutans. It's not actually probably a nystagmus, but it is something that can look like nystagmus. It's very much more rapid than most nystagmus that we see. It's a rapid horizontal or oblique oscillation. It's only in kids. It tends to be intermittent. Most of the other nystagmus I've been showing you tends to be fairly persistent and constant. It has a triad of head nodding and head turn, some of which is a compensatory thing that seems to help alleviate this eye movement, and many of them do have some strabismus or amblyopia. It's an idiopathic condition. People hypothesize that this is some sort of delay in the activation of the saccadic system, and that these are little fine saccadic intrusions, as it were. There were reports from years ago how it was associated with poor socioeconomic conditions, light deprivation. The differential, though, is not really, there are a few things that aren't idiopathic that you need to think about. One is there may be in some of these people associated retinal disease that you need to think about. Occasionally neurologic stuff, and the scary stuff here are things like tumors of the optic pathway. Some of the clues that might tell you, clinical clues that might tell you something a bit more worrisome, is that the nystagmus is actually vertical, not horizontal or oblique, and there's optic atrophy. So you watch this young boy as he watches here. Now you see that fine shimmer that comes up there? That's the movement. You see, it wasn't there all the time. It does tend to resolve in a few years, and in most of them they do vision development. Just to show you this on a little larger scale, not much to see there, but as you start to look up, there it goes. Okay. You're going to see far more often than you'll see pendulum. And we're going to talk about the ones you see in primary position. And this is a list to remind you primary position versus gaze open positional down here. So, downbeat nystagmus is probably one of the more common of the primary position ones that you'll see. These people do tend to complain of oscillopsy or blurred vision, and perhaps more so down gaze. And they often have some other signs, particularly gait imbalance. One of the curious things about this nystagmus is that it tends to get worse when they look to the side. So watch this here. See that fine? Look to the side, it starts to become aroused. The eyes are beating down. And again, there you see there. More pronounced in lateral gaze. There may be some gazeable nystagmus as well. Gazeable nystagmus in side gaze, because if you look left, it beats left. If you look right, it beats right. Here, if you look left, it beats down. If you look right, it beats down. But in that context, then for obliquely down and left gaze and down and right, lie the patient down. If we don't in the clinic, but learning about it, it's kind of one of the things we could try on a slow day. It's related to damage to the flocculus or midline dorsal medulla. It's one of the signs of a floccular syndrome. The pathophysiology is related to downward VOR pathways, which are either interrupted if medullary lesion, or else released from floccular inhibition on those patients in the cerebellum, not the medulla. This patient happened to have a lesion down here at the cervical junction, and you can see it there and there. Those pathways. Just to show you a little larger scale. Here she is looking straight. You can see the slight little downbeat. As it looks to the side, it becomes much more prominent. And also there in right case, they're really easy to see. You can see when she looks in the up case, it's still down. And that's one of the keys. It's a very persistent direction. If you see number one, should be something else at the cervical, be basilar invagination, Atlantic and rheumatoid arthritis. If you're about the cerebellar degeneration, most often this is very idiopathic form, but sometimes with alcoholic cerebellar neoplastic forms as well. Not common though. Brainstem infarct, post-faucet tumors, things that you could do to the patient in your death to this patient. Human convulsions can do this as well. Of course, if it's a treatable cause, treat it. Get rid of the lithium if you can. Treat the Wernicke's if it's a problem there. Symptomatically, I think probably one of the list these days is the diamidopyridines. I think those probably work the best. And also in the upper to make so that's left that'll be to what downbeat does, and quite as a there's two places either in the midbrain or out.
Moving down on this, torsional nystagmus is, in prime position, is pretty rare. This isn't always just pure torsional, but sometimes it's a small vertical component. Beginning can be like a heavy seesaw pattern. Two places you can get this. Again, one is up here in the midbrain, affecting the interstitial nucleus of the cow. Two is down here in the lateral pontmedullary lesion, affecting the back region of the vestibular nuclei. MS infarcts and tumors are the things we're thinking about here. Associated signs that help you localize this. If it's in the medulla, it's probably part of the Wallenberg syndrome. If it's in the pons, there may be an INO. If it's in the midbrain, there may be a vertical gaze palsy going along with this. Here's an example of a woman who had multiple sclerosis. You can see there's a small vertical twitch component. The predominant direction is torsional though, and that's conjugated both ways. And here's a bit more close up on that one eye. You see how it's turning around. This is the kind of nystagmus that's most often missed because if you just look at the subject, you don't see the eye displacing a large degree, it's just turning around an axis. The best way to see this is to look at the vessels in the conjunctiva here. You see if those are moving in a certain direction. That's a torsional movement that shouldn't be happening. Horizontal nystagmus. I divide this into two because unlike all the other movements we described so far, the torsional, upbeat, and downbeat those are all central nystagmus. Those are hardly ever caused by peripheral vestibular disease. You see that there's something wrong with the brain stem or the cerebellum. Horizontal nystagmus is different. Some of these can be caused by peripheral vestibular disease. Usually, by the rules of the game, there should be a mixed horizontal torsion thing. But once in a while, you're going to see somebody in whom, for all the world, it looks just horizontal. And that's possibly because there's an innervation or common blood supply here. One thing that could help you out here that says that this is peripheral vestibular, besides the fact they have a lot more vertigo and nausea than we expect, is that they have a positive head thrust test. And that's a sign that your horizontal semicircular canal on one side is not working. Central vestibular can also give you a pure horizontal thing. It's usually from unilateral medullary or cerebellar disease. And the nystagmus beats away from the side of the lesion. Now, these people may not have a positive head thrust test, but more likely have a problem with smooth pursuit or VR cancellation. Here's an example of a man who had a vertebral dissection here. He presented after a few days after having had a car accident with deafness in the one ear, which is a good clue that this was peripheral, as well as vertigo. And I'll show you in a little larger section in a minute. Here's his nystagmus. He says he looks straight ahead here. The eyes are slowly drifting off to the right, and the fast face is to the left. As he looks off the left gaze, that's a bit more prominent. And you see when he looks up, it still tends to beat horizontally towards the left. Now, the head thrust test is this. What we're going to try to do is we're instructing him to look straight ahead at all times, no matter what I'm doing with his head. That's my hand up there. And I'm going to quickly jerk his head off to the right. Because by doing that, I'm going to ask his right horizontal semicircular canal to respond with an increase in firing to try to push the eye back and keep it straight on the target. If that's not working, the eyes will move with the head towards the side, and after I make it jerk, they'll have to make a saccade to go back to the target. So let's see that. This is a more dramatic example. So here's looking straight ahead, a little of the nystagmus going on. I'm going to jerk his head, and you can see how his eyes end up looking off to the right, and he had to make a saccade back. Did everybody catch that? It's an important sign of unilateral vestibular hypofunction on the right side. You see, when I treat it the other side, it doesn't have a problem. That's why it makes it unilateral. If you have bilateral disease, head thrust test will be positive to either rapid movements to the right or left. This is an example of a central vestibular nystagmus in a young woman with multiple sclerosis. Here's the lesion here in the lamella, and in fact, in that lesion here, you'll see as we look directly, she looks very similar to the other fellow, in that when she looks off to that side, it's a left beating nystagmus. You can see when she's looking in the middle, the eyes kind of slowly drift to the right and are corrected by a fast pace to the left. But it's pure horizontal, just like the other fellow. But she's got MS. He had a peripheral vestibular infarct. In her, she doesn't have a positive head thrust test, but she has this. When we do VR cancellation, I'm having to try to keep looking at her hands and moving with her. You see, every time she rotates towards this side, the eyes have nystagmus. Right? She can't cancel the VR to stay on the moving hand. If VR cancellation is working perfectly, her eyes should be able to stay right smack steady in the middle of her orbit. But instead, you see jerk, jerk, jerk. Okay, jerk, jerk, jerk. There's the jerk. Right? So that's impaired VR cancellation. In her, it's a unilateral thing. It goes along with the side of the nystagmus. Now, this is a fun one. This one always confuses people because the resident goes in and tells you that they have a right beating nystagmus. You go in there, you say, no, we're talking about it's left beating. You're kind of wondering if your resident has got some problems with directional information. But both of you are right, because you're seeing the patient at different times. This thing, it causes the eyes to beat in one direction for 1 to 2 minutes, stops 5 to 20 seconds, and then goes in the other direction for 1 to 2 minutes. We'll start this video here, this young woman who had a congenital impairment. You see when she starts off, there's a little fine nystagmus that's beating. It's got a little upbeat component too as well, but it's beating primarily towards the right. And you'll see as the time goes on how it is dynamically. Now it's much more prominent, it's getting stronger and stronger. Much stronger than when we first started the videotape. And you have to be patient to see this in the clinic. You know, it takes 3 or 4 minutes for the cycle to work its way through. And if you're rushing through these people, you're not going to appreciate the fact that there's a direct a dynamic to this nystagmus. You just sit there with the video camera running, of course, and watch this. Now, this can cause oscillopsia, especially when it's in acquired form. And one of the things people do when they have this sometimes is they turn their head, because the axon is long, is they move their head in the opposite direction to the fast space. It will minimize the nystagmus. So these people may come in with a story not of periodic nystagmus, because they can't see that, but periodic head turn. It can be congenital, and in which case you have to think about all the other things that can cause congenital nystagmus, such as albinism. Or it can be acquired, in which case think about arnold-carrier malformation, cerebral degeneration, or other conditions like MS and tumors. It's due to damage to the cerebellar nodulus and uvula, which causes an unstable VR. Now you can see how she's got very little nystagmus, right, at this point. Maybe a slight upbeat at all, but horizontally it's very, very quiet now. But now what's happening? Now she's starting to beat a little bit towards the other side. Does everybody see that? So now this is when you walk and you say, what are you talking about? This is not right, nystagmus. Now it's that beat. And it starts to pick up speed again. And now it's kind of really obvious. Periodic alternating nystagmus is dear to the heart of ophthalmologists because it was really the first nystagmus for who we felt confident we had a treatment that really worked. And it turns out baclofen, that goes with 10 milligrams 3 times a day, can really knock this dead, at least for the acquired form. So now you can see quite clearly that being nystagmus. So we started the videotape, there was a little bit of right beat, acting stronger, then it died away into nothing for a few seconds, and then started slowly beating in the other direction. Gazeable nystagmus is the most common nystagmus you'll see. This is due to damage to the flocculus or and the circuit that involves the medial vestibular nucleus and the nucleus prepositus hypoglossite. Most often you're going to see this with toxins like lithium, sedatives, and anticonvulsants. It's common in the MS, which is what this woman has, and cerebellar lesions of other etiologies can also do this as well. Acid also find in some of the spinal cerebellar degeneration, such as SCA6. So again, just to show you this again, I'm sure you've all seen this.